My name is James Malatek. I'm one of the hospitalists at Georgetown Hospital, and the other hat that I wear here is I am a co-director of the patient blood management and bloodless medicine here at Georgetown Hospital. And, you know, I think I gave this lecture, I don't know, probably starting 4 or 5 years ago. And I will have to say that a lot of the residents have really improved in their, who they're giving blood transfusions to. And I think that's a testament not only to your education and what you guys are doing as far as learning who deserves blood transfusions, but also I think as medicine has grown, we've kind of been a little bit more selective and who gets blood transfusions. And I think that's a good thing. And I'm going to talk a little bit about why I think that's a good thing, and we're going to go through this. So, see my first slide here. So, I'm going to talk, basically make 3 points. We're going to talk about different particular pathologies and what are transfusion goals, and we're going to specifically look at packed red blood cells. We're not going to talk so much about FFP or platelets, as those are probably less common and probably not as pertinent right now to your education. But they do have, you do have to be selective of who gets those. And then we're also going to talk a little bit about what are the potential complications of giving packed red blood cells, why giving blood may be a problem in some patients, and then also understand the natural history of severe anemia. What happens if we don't give people blood? What becomes the problems? So, you know, let's start off with kind of the most important thing you're going to deal with in medicine is probably sepsis. And so, in honor of our interns, I'm going to talk a little bit about an intern in the ICU. So you are an ICU intern. You are doing well. Everyone has nice things to say about you, but tonight is your first night in call in the ICU. And so you're a little apprehensive. Your pager goes off and you return the call. So the nurse is telling you that Mr. Smith, he's a 70-year-old male. He's here with BPH and presenting with septic shock secondary to E. coli UTI. Mr. Smith has already required 3 liters of lactated ringers and just started some Levofed earlier to maintain his blood pressure. His evening labs come back and it shows that the hemoglobin has dropped from 11 to 9. And that his AKI is resolving. The nurse is concerned that the hemoglobin has dropped. She wants to know if we should transfuse the patient and what you should do. I just also want to, before I move forward, usually I have people asking questions, or I actually ask people during this lecture. So if you want to write in or chat, please let me know. And Carrie, if you could just look to see if there's any questions, I'm happy to stop and talk. This is lecture, because usually it's interactive, while on Zoom maybe a little bit faster, maybe like 30 minutes or so. So let's talk about what we should do in this situation. So there was a big trial that was a landmark trial in 2014 called the TRIST trial, or basically transfusions in septic shock. And it looked at multi-center randomized ICU patients with sepsis. And basically the 1,000 or so patients were very similar in their characteristics. And they put them into 2 groups. Should we transfuse them for if their hemoglobin gets less than 7, or should we transfuse them for a hemoglobin less than 9? So what they found when they looked at all these patients is that there was no real significant difference between whether you shot for a higher hemoglobin threshold versus a lower hemoglobin threshold in someone who comes in with septic shock. So it kind of made you think, well, there's no benefit in giving someone a transfusion in sepsis. What about, is there some sort of risk? So looking back in 1999, there was actually something called the TRIC trial, which didn't look specifically at septic patients, but did look at critical care patients. And this was published in New England Journal of Medicine. And it looked at about 800 ICU patients, and they were randomized to a restrictive pattern or a liberal pattern. And they basically looked at their outcomes, right? And so what they found, just like in the TRIC trial, that giving blood transfusions or holding blood transfusions didn't really have a statistical significance in outcomes. So you didn't live longer if you got a blood transfusion. In fact, there was a trend that people died more often when they got liberal blood transfusion. And when they broke it down even more and looked exactly at why there was this trend, It was found that patients with an Apache score of less than 20 or patients younger than 55 actually did have a statistically significant worse outcomes if they were given blood, right? So my conclusion from that, and the author's conclusion from that, was that the healthier you are, the more likely giving them blood may cause them to have bad outcomes, right? So if they were kind of a borderline ICU player, right, with an Apache that wasn't that high, if you gave them blood, you actually could have caused more problems, okay? So breaking down until, well, why did they have more problems? And besides death, was there any complications? And there certainly was. So the patients who got more blood, they had statistically more likely to get myocardial infarctions. They were statistically more likely to have pulmonary edema. And there was there was a trend that they would have more ARDS. Okay, so and the increase in between these two, right? This is fourfold. This is almost 2 times fold, and this is 50% increase. And so giving blood does not seem to be benign. It seems to be a potential complications that can occur with it. And so when you're making a decision whether someone needs to have blood or not, and I do a lot of down talking about giving blood transfusions. They can be life-saving, and so we should know that. But there's potential complications. You have to have a very good reason as to why you're giving someone blood. And so it looks like Raul with Float CCC asked, why is there more MIs? Why would they have more MIs? And we're going to talk a little bit about people with ACS and why getting blood transfusions may be harmful to them. But let's move forward, and I'll try to come back to that for the myocardial infarction, Raul. Okay, so what if Mr. Smith's hemoglobin, instead of going from 11 to 9, went from 8.5 to 6.5? So currently, the surviving sepsis, which were updated in 2000, the guidelines, which were updated in 2017, use a hemoglobin of 7 that we would transfuse. So in that situation, if Mr. Smith went from 8.5 to 6.5, and he was in sepsis or septic shock, you would give him blood. This goes against the earlier data that Rivers, which was this landmark trial, I think in 2001, which basically had a whole, this is the algorithm that Rivers followed, which basically we have taken from that. You need to give them fluids and antibiotics as early as possible. But this whole checking the mixed venous sats, and if it's less than 70, giving them blood, this is a whole thing that we have gotten away from in the ICU and on the floors. So really our hemoglobin goal in these patients is greater than 7. Whether it's going to be in the future less than 7, we don't know, because we haven't really looked at people who have a hemoglobins of 6 versus 7. So that may change in the future. But for right now, we do not, the hemoglobin goal in someone who is septic is 7. And there's some pretty good evidence of why to do it. So as far as sepsis and anemia, right? So septic patients in the ICU should generally have a hemoglobin of 7 based on guidelines. Now, this may change if they have other potential issues, and we're going to talk about them later. Do they have acute coronary syndrome while they're having sepsis? Do they have coronary artery disease? Are they bleeding? Those type of things may change. But in someone who is just a clear septic patient who is in the ICU, you shoot for a hemoglobin of 7. And that may change, just like 50% of the stuff you learned in medical school changes by the time you're done your career. This may change in the future. We just haven't really studied hemoglobin of 7 versus hemoglobin of 6 or 6.5. And then patients who received transfusions liberally, well, they had worse outcomes. And so be very careful when you're giving blood transfusions. We used to give 2 units, just because if you're going to give it, you might as well tank them up. We've really gotten away from that. And I don't think any of the interns or residents do that anymore. But when I was studying, or when I was in residency, which was only 7 years ago, we used to give 2 units at a time. So things certainly changed throughout your career, and I expect this will probably change as well. Okay, so Mr. Smith's niece. So you're still in the ICU, and Mr. Smith's niece calls the unit to fill you in on some more medical history, and lets you know that Mr. Smith had cardiac catheterization 2 years ago and was diagnosed with 2 vessels coronary artery disease, which had been medically treated at the time. And still is being medically treated. The nurse calls you and says, do you want to transfer Mr. Smith, or transfuse Mr. Smith, because she used to work in the CCU and a hemoglobin of 10 in cardiac patients. She also mentions that Mr. Smith is complaining of chest pain. So before we move on, I will say from a personal history, when I was a resident, I remember talking to one of the cardiac fellows in residency about a patient who was having chest pain and his hemoglobin, I think, was 9 at the time. And he told me we need to get his hemoglobin goal up to 10. And so he said, transfuse the patients. And then after my 4-year med peds residency, I was in my last year of med peds, and the same fellow was on, and I think he was an interventionalist at the time. And I called him about a very similar patient, and I told him I'm going to give him a unit of blood because hemoglobin is 9 to get him up to 10 because he is having chest pain. And the fellow asked me, well, why are you doing that? And I said, because you taught me that. And that's how quickly this stuff changes. And you know, now is not the time. We'll look more at the studies about why that's not appropriate, but this stuff will change, and so you need to continue to keep educating yourself. And I suspect transfusion goals will certainly change over time. Let's move forward here. Okay, so initially his troponin was 1.4, which I guess I just changed. It's probably 1400 in the new high sensitivity tropes. I think that's correct. I think it's like a times 1,000. The EKG has ST depressions and leads 2, 3 in AVF, and you're appropriately concerned about ACS. Given his hemoglobin of 9, what do you want? Do you want to transfuse him? So the first reason, or the first kind of analysis looking at people with anemia and acute coronary syndrome was actually a post hoc analysis looking at these large studies that were looking at other things in ACS, the Gusto, the Paragon, and the Pursuit trial. And it looked at 24,000 patients, and this was in 2014 in JAMA. So it was a very large trial, but again, it was observational and it was looking back. And they looked at people who got transfusions and versus no transfusions. Okay, and this is mortality. It's a little bit blurry here, so I apologize, but this is basically death. And so this is 8% of the patients who got blood transfusions who are having ACS, they ended up dying, versus about 3% of the patients who did not get transfusions at 30 days. And so this is pretty significant, you know, and they actually had 25 more MIs, 25 versus 8 MIs in the two groups, recurrent MIs after their initial one. And so it's tough to parse out why this happened. Like Raul was asking, why would this happen when you think blood would lead to more perfusion of the heart? But it may be because the sicker patients were the ones who got blood, right? So did they get blood, and that was because they were still having chest pain and they were sicker because they had worse disease. And so what you really need is a randomized controlled trial. And so there has been 2 that I can find to the date as far as looking at randomized control trials and using different hematocrit or hemoglobin goals. And so this one was done 45 patients who were all having ACS. And they initially came in with a hematocrit less than 30, and they are having ACS. One of the hospitals involved was actually Washington Hospital Center, and also the VA in Washington. And they put them into 2 groups. So basically get their hemoglobin up above 10, like, or hematocrit at 30, like the fellow when I was in residency told me to do initially, versus a conservative, which said, let's get the hematocrit between 24 and 27. Okay. So the liberal group, all of them got blood, and they had a median of 2.5 units during their stay, versus the conservative group, who got about 54 of them, or half of them got blood transfusion, and they got about 1.6 units per their stay. And they looked at death, recurrent MI, and worsening CHF. So what we ended up finding, or what they ended up finding, was that in the liberal groups, the patients who got more blood they ended up dying more often. So you can see 38%, which is crazy, right? I guess it's 21 patients, so 7 or so patients, versus the conservative group, only 13% died. And that was clinically significant. And then did they get worse heart failure? Sure. And that kind of makes sense, that they got volume overloaded, their heart had to work harder, and that may have been the reason why they get more demand ischemia or recurrent MIs. And then if you looked at 30 days, there was certainly statistical significance between the two. So unfortunately, at the same time, or around the same time, there's another study that came out, looked very similar. It had 110 patients, and they had ACS or stable angina, and they were getting casts, and they had a hemoglobin of less than 10. And so they put them into a liberal group, so hemoglobin of 10, or very similar to that hematocrit group before, and a conservative group, which was greater than 8. They kept the hemoglobin. And so you can see the units. So these people got certainly less units than this group. And they looked again at death, recurrent MI, or unscheduled catheterization at 30 days. So similar outcomes that they were following. And what they found is the people who had hemoglobin of 8, well, they died more often, and it was statistically significant compared to the hemoglobin of 10. Well, sorry, it wasn't statistically significant. I don't have the p-value. It was 0.054, so very close to being statistically significant in the liberal group, having more have better outcomes. So this goes against what we just saw, and so I think there's certainly we need more randomized controlled trials to evaluate what's the best thing to do in this situation. So right now the ACP, and this is not ACS, but the ACP says for patients with coronary artery disease to keep their hemoglobin between 7 and 8. And this is weak recommendations. And they also don't want to give people EPO, which we're not going to get into right now, but there's pretty good data showing that giving EPO to patients with coronary artery disease or heart failure leads to worse outcomes. So the data is confusing in people with acute coronary syndrome. Where should we shoot for hemoglobin? Currently, the guidelines say 8. However, I talked to a bunch of cardiologists that have trained at Georgetown or Washington Hospital Center, and they use 8 as their guideline. However, they may give more blood and give another unit of blood if they're still having chest pain, if they've got severe coronary disease like 3-vessel disease, and this is after they've kind of titrated up their anti-anginal medications. One of the other cardiologists actually told me that would probably push him to try to get him into a cath lab earlier than later. So, I think this is still pretty nebulous. I think you're safe at saying, let's get him up to 8. And then if he's still having chest pain, talking with the cardiologist about if there's a good idea to give more blood. This is still this is still, it's not the 7 that we know of. The 8 seems to be the guideline right now. I don't suspect this is going to drop, as it seems like there's some sort of inflection point between 8 and 10 based on the 2 trials that I just talked about, but we'll have to see moving forward as more data comes out. I don't know if that answers your question, Raul, but that's kind of my thought of why they had more MIs. It seems like blood doesn't always give you a better perfusion of the heart. Sometimes it can lead to more stress and more demand ischemia. Okay, you're welcome. Okay, moving on. We've got other conditions to look at. So Mr. Smith, he's actually doing okay right now, but his roommate, while you're in there evaluating for chest pain, his roommate who's got cirrhosis and esophageal varices just has I said moderate melanotic stool, large, he has a melanotic stool. And his hemoglobin, which is now 7.8, this is the neighbor, is down from 9 earlier in the day. Hemodynamically, he's stable. Besides, you call GI and ask them to come in to scope him because you're in the ICU, and they can do that. Should you transfuse this guy? And what's your hemoglobin goal? So another landmark trial that came out in New England Journal of Medicine in 2013, which looked at 921 patients with upper GI bleeds. Okay, this is just anyone that's peptic ulcer disease, esophageal varices, gastritis. It looked at all patients with this. It did remove anybody who has hemodynamic instability, right? So the patients who are hypotensive, that's not who we're looking at right now. These are patients who are not hypotensive or tachycardic to the 150s or something. These are patients who have hemodynamics that are stable. and we looked at using different transfusion goals. So similar to the ACS, they looked at hemoglobin keeping it above 7 and hemoglobin keeping above 9. Okay, so in the group that was to keep above 7, 51% of them, so about half of them got transfusions, half of them didn't. And their mean transfusion packed red blood cells was about 1.7. And the patients who were shooting for an upper goal, almost all of them got blood transfusions, all but 16%. And their goal was between 9 and 11, and they got about almost 4 units of blood. And so here's their outcomes here. And as you can see, and why I've been kind of saying don't just give blood, is that the restrictive strategy seemed to be more helpful than the liberal strategy. And so when we kind of break this down more, it seems like the driving force between this difference in this study was actually the cirrhotics, the child's Pew A and B. And so these were probably esophageal varices that were bleeding. And the thought was that by giving more blood volume, you had a potential stable clot in the varices that became unstable and you had more rebleeds. And so there was actually a 10% increase in rebleeding compared to this, an increase in 10% in the liberal strategy by giving them more blood than there was in restrictive strategy. So giving more blood seemed to cause them to have more bleeding. They also had more adverse events in the liberal group. And then as well as this was the driving behind this, like we saw in the trick trial, was pulmonary edema and ACS and transfusion reactions. So, right now, let me go kind of back here to this. So this is so for patients with a upper GI bleed, our hemoglobin goal is to keep it greater than 7. And the patients that seem to benefit most from using this lower goal seem to be the cirrhotics. And this is Georgetown, so you're going to see a lot of cirrhotics. But let me throw the caveat out there, is if the patient is hemodynamically unstable or having large bleeds, you give them blood, okay? If you wait, that might be too late. They may get hypotensive, more hypotensive, they may not perfuse their brain, they may not perfuse their organs, and it might be a problem. So in patients who are hemodynamically unstable, there's not a hemoglobin goal. It's to give them blood to keep them hemodynamically stable until you can stop the bleeding. In patients who have a stable blood, we now shoot for 7. Do you have any questions about that? Let me see, any more questions? No questions right now. Okay, so let's keep moving along. So 7 days later, Mr. Smith is on the mend. He is ready for discharge. However, in his eagerness to discharge, he falls transferring to the commode. Unfortunately, he breaks his hip. He's taken emergently to the OR, and his hip is pinned. After 4 more days, he is now ready for acute rehab. His hemoglobin is 8.2, and ortho wants to give him a transfusion to tank him up and give him a little bit of extra energy for rehab. He recommends against it. The ortho resident wants to know why. So there is a study from 2011 that in New England Journal of Medicine that was multi-centered randomized controlled trial that looked at patients who had hip fractures. They were greater than 50, they had hemoglobins less than 10, and they had potential coronary disease or risk factors for coronary disease. And they were put into 2 groups, a liberal group and a restrictive group. And so these guys, we tried to keep their hemoglobin above 10. These guys try to keep their hemoglobin above 8. And this restrictive group also included people who had symptomatic anemia. So if their hemoglobin was 8.2, but they were tachycardic or having chest pain or shortness of breath, they were allowed to get a transfusion. Or physician discretion, which they didn't really explain too much, but I guess if the physician thought this guy needs a transfusion, he got a transfusion. And the primary outcomes were death and ability to ambulate across the room at 60 days. And so there was no difference between those two. So giving them blood to get them ready for rehab, to get them stronger, which is not something that I haven't been asked by different surgical subspecialists, is not something that is probably appropriate and actually can lead to worse outcomes for your patients. And like I said, blood transfusions are not benign, just the act of giving them blood. So let's talk about that a little bit. So when I consent someone for blood, I really talk to them about, you have a potential, we screen all the blood for a potential infection, but there is a potential that you could get it. You could have an allergic reaction, or you could have more difficulty getting blood in the future because you developed antibodies against blood, so alloimmunization. But there's certainly way more risk than that, right? So this is taken from one of the physicians at Johns Hopkins. And basically, here are some risk factors with blood transfusions. You know, I kind of roll these all up into one thing when I'm talking to a patient, but in medicine, you might see these things. So you could get some allergic or urticarial reaction in 1 out of every 100. So the alloimmunization happens in 1 in 100. TACO, right? So transfusion associated cardiac output or cardiac overload, right? So they can get kind of pulmonary edema or volume overload just from giving them blood, which mostly all stays within the blood vessel, can occur, and that happens in 1 in 100. Trolley, where you actually get associated lung injury, can occur in 1 in 5,000. I've seen that happen, and people have gone to the unit. You can also, every time you give them blood, there's a potential to have a hemolytic reaction, right? When you give them some blood, or you can actually give them the wrong unit. I've not seen that happen yet, but I'm sure the longer my career goes, it can occur. And then the most, the least common is hepatitis B, hepatitis C, and HIV, which are between 1 in 200,000 or 1 in 2 million. So you give enough of us give enough blood, we're going to give someone hepatitis B. And so you need to be sure that what you're doing is the right thing for the patient. Now, blood can be, I've talked talked down to blood, but it can be life saving. And so I think we need to know who are the patients that will benefit and who are the patients that may be harmed. And you need to think about that every time you think about giving blood. And you should always give it just 1 unit at a time. So let's continue to move on. Talk a little bit about potential nosocomial infections that can occur with blood. So there's a trial that came out in 2006 from one hospital that was a prospective observational cohort study. It looked at about 2,000 patients and looked at nosocomial infections in patients who got transfusions and ones who didn't. And if they had gotten a nosocomial infection before they got a blood transfusion, they were put in the nosocomial non-transfusion group. And so what we found, or what they found, was that about 7.5 of the patients got nosocomial infections, and the ones who got transfused got a significantly more nosocomial. 14% of them got nosocomial infections versus less than 6 in the non-transfused. Now, just like in prior studies, it's very difficult to tell whether this is because of the blood transfusion or because they're sicker, and sicker people get nosocomial transfusions and they also get blood transfusions. But it's enough to give me pause to say that, giving a blood transfusion without a very good reason can really cause a lot of harm to my patients. And if you actually looked at the number needed to give someone a nosocomial infection, was actually 48, which is, it's the number needed to treat, I guess, or number needed to harm was 48, which is high, but not compared to a lot of other things we do. And if you add up lots of different things, if you're not doing for your patient, you can end up hurting them. Okay, so what if we decided that blood transfusions were just not something we would do for patients? What would happen? And so there actually is a population of people, the Jehovah's Witnesses, that a lot of times refuse transfusions, and they do this for religious reasons, and they're very stern and strong in their thoughts. I've seen people die because they don't want blood transfusions, and so they're very very appropriately strong in their beliefs, and they feel that this is something that they don't want. And so, but what can we learn from them looking at the rest of the population? And so this is a study from 1994 that looked at 134 patients who all had anemia, hemoglobin's less than 8. And they looked to see what caused them to die. And so there's 50 deaths, and the ones that were deemed primarily due to anemia, most of them, almost all of them, besides the 3 post-cardiac surgery patients, they died when their hemoglobin got less than 5. And in fact, not everyone died, because 25 people survived with their hemoglobin less than 5. And if you've seen on the wards, there's people who have hemoglobins in 2 and 3 who are Jehovah Witness patients, and they don't just die, right? So I think that we need to, not have this reactionary, let's transfuse a patient if their hemoglobin's less than 7, because, it's probably as we move further in time that the hemoglobin goals are going to drop for different patients, right? That maybe 7 on all comers is not what it's going to be. Maybe it's going to be 6, or maybe it's going to be 6.5, or maybe it's going to be closer to 5 before we need to transfuse patients. Okay, so kind of my final take-home messages are, in patients with septic shock and upper GI bleed, and this is, the caveat is patients who are not hemodynamically unstable in upper GI bleed, our hemoglobin goal is 7. And people who have had hip surgery, acute coronary syndrome, or recent cardiac surgery, probably the goal is to get it greater than 8. And then I think the one thing that I've alluded to is that these patients that are healthy, that are not having chest pain, that are not, symptomatic, if their hemoglobin drops below 7, you don't need to give them a unit of blood and then call it a day. You need to figure out why they're anemic and try to treat the underlying cause. A lot of times I'll come in the morning and a patient who got admitted overnight, their hemoglobin was 6.6. We don't know why, but got a unit of blood, and that's done. And we haven't done a workup to try to figure out why. And once someone gets someone's blood, now it's going to cloud the picture a little bit. So I think you don't always need to give someone hemoglobin when they drop below 7. You need to think about, do I need to give them blood? And if not, how am I going to fix this problem? So in addition to giving blood, you can have certainly a lot of different reactions to getting blood that are all not very good, right? So there's strong correlation with mortality, nosocomial infection, longer hospital stay. Now, to say that this is a definitive, there's definitely a correlation, but if this is a really direct cause, it's unclear. Sicker patients get more blood, and sicker patients die more often. They stay in the hospital longer, and they get nosocomial infections. But it's enough, at least for me, to have pause as far as, is this blood transfusion beneficial to my patient? If not, it may be harmful, and we need to stay away from that. And then finally, based on the data from the Jehovah's Witness populations, hemoglobin of less than 5 may eventually end up being the inflection point. I think it's too early to say that. Maybe it's going to end up being 6, but there's going to need to be more studies. And I think it's very possible that in 5 years, I'm giving this lecture, and 6.5 is now our transfusion threshold for a relatively healthy person. Guess I can take some questions now if anybody has questions. I know it's not a very long lecture, but residents don't seem to have a problem with that. And let's see what the questions are. All right, hyperbaric oxygen. Which patients qualify for that and the indications? So right now, I don't think there's really an indication for hyperbaric oxygenation in patients who are anemic. In the Jehovah's Witness population, I think we're starting to see that there may be this paradoxical effect of giving them hyperbaric oxygenation actually increases their reticulocyte count. Exactly why this happens, I'm not aware of exactly why this happens. I don't think anyone really knows yet. Normally what drives you to make more reticulocytes is being hypoxic. So the fact that when we give them hyperbaric and make them hyperoxemic causes them to have more retics, it's unclear. So really we kind of save that right now for patients who need, healing of wounds, or Jehovah's Witnesses. And I think we're still trying to figure that out as far as what the indications are. But I think those are the two right now that I can think of, is wound healing and Jehovah's Witnesses with severe anemia. And then please give guidance on symptomatic anemia and hemodynamic. During my chart review, tachycardia may be the only symptom documented in transfusion with a hemoglobin close but to above 7. So, I think certainly tachycardia, if you think that's secondary to them being anemic, that would be an indication that they are symptomatic. So that the current recommendations are probably you can give them blood. I think, I wouldn't just all of a sudden give them blood if their heart rate is, 110 and they're relatively stable. I would try to figure out why they're tachycardic or why they're anemic and try to fix that problem, right? If they're iron deficient, I can give them iron. And if they're 110, I don't need to just hurry give them blood and to make their heart rate, 99. I think you need to figure out how to give them, to treat their anemia. And then I think if they're hypotensive and anemic, I think that seems to be a good reason for a blood transfusion, especially if they're actively bleeding.